content, okay? Because of course it's very, very different than the mental health that you just covered. For those of you that don't know me, I'm Miss Rumble. I teach a lot of perfusion related concepts in 114, 102, 103, and 213. So perfusion is my favorite topic. And I wanted you to know that you're going to need to start with the cardiac pharmacology, because there are so many medications that are given to help the myocardium, okay? So what I have posted, and I'll share my screen in a minute, you will see the regular cardiac pharmacology slides, okay? I did go ahead because we will not get through this by any means. We will pick this back up on Monday. So I went ahead and posted the pharmacology voiceovers. It's an additional resource. That's all. But we will go back through pharmacology on Monday. But I did post those just in case you wanted to listen to the material. Now, just remember the problem with those. Oh, you're welcome. The problem with those voiceovers, they take forever to open. So you have to be patient for that. I will also, I'm very big on handouts. I'll be posting assignments in Swift River that aligns with your content. I do not require it, but since it aligns with the content, most students find it a very good resource as well. And I think that's important, that you have multiple resources to try and learn this material. It is a lot of material, but you will do fine and get through it. And I'm going to share my screen, okay, while we get started here. So what you're going to find is there is just a lot of cardiac meds, okay, a lot. So really what can I say? The best way to learn these is by learning classes, okay? And that's how pretty much the majority of students learn medications for the boards. They learn classes, because you cannot learn every single medication for the state boards, okay? But cardiac is a big one, okay, as far as pharmacology. So I'm just going to try and get through what we can. And then I'm also very big, we'll go back over content discussed on Wednesday and then progress forward with our cardiac pharmacology, okay? The other slides posted, you will find that we cover CAD, heart failure, hypertension, peripheral arterial and vascular disease as well. So that's a lot of material as well. So but we'll get through it. The first class I would like for you to look at is the class of beta blockers. Now, one thing you need to look at is this slide right here. These are the beta receptors, beta 1 and beta 2, okay? Now, when initiated, the beta 1 receptors increase heart rate. The beta 2 receptors dilate the bronchioles. okay? So why is that important? Well, let's now look at one of our first medications called beta blockers. Beta blockers end in OLOL, O-L-O-L, okay? They have a lot of uses, as you can see, to help the myocardium. Okay, they can be used for anti-anginal. Angina is what we refer to in the lay term for angina is chest pain. Okay, but healthcare, we as nurses, we call it angina. Dysrhythmias, so it can help block dysrhythmias, which would be a heartbeat that is not normal. They can also be used as antihypertensives. So by blocking, now go back to this, by blocking the beta-1 receptors, they lower heart rate and they lower blood pressure. So again, why would that be important with someone who has heart disease? Well, because a patient with heart disease, their hearts can't tolerate high heart rates and high blood pressure, okay? Because that increases the workload of the myocardium. So it's important for those patients. Oh, okay, she's telling everyone, yeah, decreases the workload of the heart. And that's important for your patients that have cardiac disease, okay, to try and, again, protect that myocardium so that they do not have an increased workload, okay? So we're talking about a patient with cardiac disease, which there are a lot of patients with cardiac disease. Now, I will tell you the most common side effects of a beta blocker are going to be bradycardia and hypotension. So that's truly what you're watching out for, is bradycardia and hypotension. Now, you have not talked about heart block. You will in 213. These are when we would not give a beta blocker. Why would we not give a beta blocker to someone with lung disease? Well, think about it. So it's blocking beta-1 to decrease heart rate and blood pressure, but when you block beta-2, you're causing bronchial vasoconstriction. So beta blockers can be a problem for patients with pulmonary disease. Now, I will tell you, over time, our medications have improved drastically, and I'll explain that in just a minute. Here are examples of all different types of beta blockers. And notice they all end in O-L-O-L, okay? Now, this is what I meant by these medications have advanced over time. Back in my day, and I've been a nurse a long time, and I'm cardiovascular, that's where I've spent my career pretty much. So in my day, we had what was called, if you'll think of first generation beta blockers, okay? They were truly called non-cardioselective, or just think of them as first generation, okay? They did, you can see, end in O-law. One of the big ones that I gave pretty much all the time was propranolol. those first generation beta blockers worked very well on beta 1, but unfortunately they worked well on beta 2. So it was a problem back then for our patients with pulmonary disease because it would cause the bronchial vasoconstriction. But now in your generation, we have with generation of nurses, we now have the second generation, and we refer to them as cardioselective. You can see your metoprolol is a very popular beta blocker. And why is this a good thing? Because the cardioselective beta blockers work really well on beta 1, but they don't have as much of effect on beta 2. So they're better now, these beta blockers, in that they can be given to patients with pulmonary disease and not cause extreme bronchial vasoconstriction. So that's been a good thing with research, okay? Again, OLAs are your beta blockers. We give them all the time in the hospital. Again, your big ones are right here: bradycardia and hypotension. So you should always try to teach my students, when you're looking at vital signs, make sure you're looking at trends, because we know that patients vary in what their blood pressure is and what their heart rate is. So make sure you're monitoring those trends and vital signs. You should always check a patient's heart rate and blood pressure prior to giving a beta blocker, okay? And now you should have parameters. What do I mean? They should have in that MAR, like, do not administer if heart rate less than 55, or systolic blood pressure less than 90. You guys should have parameters, because you have to remember you want to give that medication because it decreases the myocardial workload, the workload of the heart. So what happens then is, nurses will get nervous about giving them if their heart rate, say, is 65. Well, again, you have to look at that patient. That may be where that patient's heart rate needs to be. So, and I'm not saying don't question it, guys. It's just you should have parameters, because that was something we didn't have way back when, and that was not good. You should have parameters from the physician whether to give that medicine or not. Cardiac meds are very important meds. And sometimes, I have often been with my students and said, well, you know what, instead of not giving it, let's just wait an hour and hold on, I'll answer that. Let's just wait an hour and then let's reassess. Let's reassess that blood pressure and heart rate and see if it's okay to give, because I don't want to hold it. But obviously within the hour, if it's not where I feel comfortable giving it, then I let the nurse know. And but sometimes nurses will wait. So just make sure you're looking at any parameters. Okay, so I have a question. So beta 2 blockers constrict or dilate the bronchioles. Beta 2, okay, let's go back over that. If we look at our beta receptors, beta 1 increases heart rate and blood pressure. Beta 2 dilates the bronchioles. So now think about it. Now we're going to block beta 1 and beta 2. So if I block beta 1, then I lower heart rate and blood pressure. If I block beta 2, then I can cause pulmonary vasoconstriction. Okay. Now, like I said, we've gotten a lot better with our beta blockers with research. Back in my day, where you had first generation beta blockers, yes, I saw bronchial constriction in these patients with like COPD, okay? Where now with the second generation beta blockers, we see less bronchial constriction. Now, I'm not saying it can't happen, but we see less because the medications have been perfected so much better. So with beta blockers, they decrease heart rate, decrease blood pressure. Second generation beta blockers cause less bronchial constriction, but they can cause bronchial constriction, but they're better now. So I hope that answers that question. I try to always take questions from the chat and verbally give that information to all students, because sometimes that obviously there's another student who is like, wait a minute, I didn't get that. So your big side effects, bradycardia, hypotension, you should have parameters on your MAR. And also you need to educate that these drugs should not be stopped abruptly, okay? Because they can have what we called rebound. We called it rebound tachycardia because they've been taking this medication and the medication's been blocking those receptors. So if they abruptly stop it, they will get rebound effects like tachycardia, hypertension, etc. So they should never stop them abruptly. Here's, hold on. So first generation beta blockers shouldn't be given to people with chronic because it increases. Yes, that is correct. The student asked, so first generation beta blockers shouldn't be given to people with chronic lung conditions because it increases the workload on the lungs. Yes, it causes vasoconstriction of the bronchiole. That is correct. Here's just another visual to remind you about the class, N's and O law, and what beta blockers actually do. The big side effects I've already mentioned are your bradycardia and hypotension. Big class and used a lot. Now, our next class of medications is your calcium channel blockers. This slide here is just a mnemonic to look at examples of calcium channel blockers. And that mnemonic is very nice drugs, VND. That stands for verapamil, nifedipine, and diltiazem, which are calcium channel blockers, okay? So I want to go into more detail now with your calcium channel blockers, okay? So as you can see, they can be used as anti-anginal for chest pain, antihypertensives, They can also decrease the heart rate, and therefore decrease that myocardial workload, okay? And by decreasing your myocardial workload, what happens is that's what increases blood flow from the heart and, of course, oxygen to the organs and the tissues. So they're going to block calcium across the cell membrane, and that is how they do what they do. So I mentioned why they're given. Again, your big adverse reactions are your hypotension and bradycardia, okay? Those are your big two. Now, I'll tell you about, but that comes with another. These two are your big adverse reactions. So if you're giving it IV push, I don't care what cardiac meds you give IV push, you need to follow the Gay Heart guidelines and give it slowly and monitor their heart rate and blood pressure, because IV calcium channel blockers, IV beta blockers, they can drop someone's blood pressure and heart rate very quickly. So you should have to be very careful about the IV push. All right, now this is why I wanted to explain a little bit more about calcium channel blockers, okay? Now, if you'll go down to the bottom, you have multiple, what we call, you can call them depines or depines, doesn't matter. And you can see the list I have here for you. Amlodipine, nifedipine, nicardipine, okay? So I call them the depines. But the big thing is they contain a chemical. You do not need to know that chemical. I'm just telling you the difference in these meds. And they're all calcium channel blockers. So the depines contain that chemical. So they work better to cause peripheral vasodilation, which lowers blood pressure, okay? Now, your other two, your diltiazem and your verapamil, that should be verapamil, okay, but diltiazem and verapamil do not have that chemical. So they work best to lower heart rate. They're all calcium channel blockers, but they do work a little bit differently, okay? And that is why, because one of them, the depines have that chemical, causes peripheral vasodilation to occur and lowers blood pressure. Diltiazem and verapamil do not have that chemical, so they work best at lowering heart rate. They're all calcium channel blockers. Our next class is a big class, and most of you I have heard of them, and that is your ACE inhibitors. We give a lot of ACE inhibitors. Now, this is to help you understand how these medications work. Now, when your kidneys do not get adequate blood flow, that could be for a variety of reasons, okay? That could be due to heart disease, that could be due to heart failure, that could be due to myocardial infarction. When the kidneys do not get enough blood flow, this is really a compensatory response. Just like when the brain doesn't get enough blood flow, it sends a message to the heart to increase blood flow because the brain demands blood flow, oxygen and glucose, okay? Now, when the kidneys don't get blood flow, you're not getting enough oxygen, they release what is called renin, okay? A chemical called renin. That is going to lead to the activation of angiotensin 1. So with that enzyme, ACE, you can see it right here, ACE, that enzyme causes angiotensin 1 to convert to angiotensin 2. Look what happens. Angiotensin 2 is going to cause vasoconstriction to the periphery to increase blood flow to the vital organs. With the release of angiotensin, we also have the release of aldosterone. Aldosterone is telling the body to hold on to sodium and water. So that is a compensatory response to try and protect the body. But over time, that is not protecting the body. That's only increasing the workload of the myocardium. So let me point out right here, you can see that enzyme ACE with your ACE inhibitors is now blocked. That's what ACE inhibitors do. They block that enzyme. So angiotensin 1 does not go to angiotensin 2. And you don't get that powerful vasoconstriction when you take an ACE inhibitor. And you don't get retention of sodium and water with ACE inhibitors, okay? So when you block that ACE, you don't have vasoconstriction, you don't have release of aldosterone, you don't have retention of sodium with water, okay? With the loss of sodium and water, you do hold on to potassium, okay? With your ACE inhibitors, you're gonna hold on to potassium. ACE inhibitors, again, are used a lot for hypertension in particular. You don't hold on to sodium and water, but you will hold on to potassium. So you always have to teach your patients on ACE inhibitors to avoid like salt substitutes, okay? Because most salt substitutes are potassium. When you use ACE, does it still convert to angiotensin 2? So what the student's asking, when you use a ACE inhibitor, will it convert to angiotensin 2? No, it will not. That's how it lowers blood pressure. Frequently used for hypertension. Now, let me also say this. I mean, it's going to depend on the patient, but oftentimes you will see ACE inhibitors given with like a mild thiazide diuretic, and that's called hydrochlorothiazide, okay? HCTZ. So they're often given with the ACE inhibitor to balance out. It could be to provide more diuresing and to balance out that potassium, okay? ACE inhibitors end in pril, P-R-I-L. They're the prils. Okay, the one particular reaction that can happen with an ACE inhibitor is a dry, hacky cough. Some patients get it, others do not. We don't know exactly why some get it and others do not. But a dry, hacky cough. So we always tell the patient, if you have that side effect, please call us and we can switch you to another medication. The cough is initiated when you block ACE, you release bradykinin, but we don't know what happens in some patients and not others. So with a dry, hacky cough, we tell them not to stop their meds, to call, and we can switch them to another medication. A very major adverse reaction that can occur with ACE inhibitors, and we often see this in the African American population, and that is called angioedema. That's where the tongue can swell to the point it blocks the airway, and they have to be trached. They have to get a tracheostomy. So that's a very major adverse reaction. Like I said, that tongue can swell to the point it blocks the airway, and they will do a tracheostomy, and they should never take ACE inhibitors. Here's some examples. ACE inhibitors are the prills. The prills. That's an excellent question. Is that angioedema reversible? Yes. It can take it can take up to 72 hours, but the swelling will go down when the medication is stopped. And that patient should always have that listed in their chart, obviously. The prills. Okay, now we have another set of class of medications called angiotensin receptor blockers, or angiotensin reverse blockers. Now, if you will, go back to our RAAS, our renin-angiotensin-aldosterone system, which we know that the kidneys, if they're not getting enough blood flow and oxygen, they're going to initiate renin, okay? And the cycle begins. Now, remember where I said ACE inhibitors block right here, the enzyme ACE? Angiotensin reverse or receptor blockers are blocking angiotensin 2. So they're blocking angiotensin 2 from working, so that you don't get that vasoconstriction, you don't get the release of aldosterone, and you don't get the retention of sodium and water. So they work to block angiotensin 2, okay? Now, I will say this, if your patient had angioedema, they do not recommend that patient take an ACE, obviously, or an ARB, okay? The chance of angioedema is much, much less with we call them ARBs, much less, but still, if that patient has had an episode of angioedema, they do not recommend for those patients to take ACE inhibitors or ARBs. You'll hear it called ARBs. They end in, if you'll look right here, sartan, S-A-R-T-A-N, sartans. We do see much less incidence of coughing, that dry, hacky cough. But they're the sartans. They are more expensive. ACE inhibitors are now on your $4 list, so they're often prescribed more. But you will see people on the angiotensin receptor blockers, okay? Much less incidence of cough, and therefore those patients become ideal for an ARB. They all end in sartan, okay? This is just a slide again showing you where these medications work and how they prevent that peripheral vasoconstriction and prevent the release of aldosterone, which therefore you don't hold on to sodium in water. Hold on. There we go. Okay, let me share my screen. Okay, well, I need my mouse to work, guys. Hold on. Oh, here we go. Technical difficulty. Okay, our next set of medications are called, we're getting into now what we call alpha blockers. But this is a very old medication, but it's called a direct arterial vasodilator, and it's hydralazine, brand name of Presaline. Often used for hypertension. Your big side effects are your hypotension. That's going to be your big side effect, is hypotension. A Presaline can be given by mouth, IM. We don't do much IMs anymore, or it can be given IV. So it is a direct arterial vasodilator. Again, any IV cardiac meds you give, you watch that patient, because you can drop their blood pressure down to the bottom. So your alpha, these are your alpha blockers, okay? Your first alpha blockers are your alpha 1 blockers, okay? Alpha 1 blockers. They're used to treat hypertension, and one of them is used to treat benign prostatic hypertrophy, or BPH. Big side effect.
Can you say that again? BPH?
BPH, benign prostatic hypertrophy. It's when the prostate enlarges. You see it in older men, and they have they can have urinary frequency, inability to, initiate urine, things like that. Okay, a big side effect of these drugs is not just the obvious, which is hypotension, but orthostatic hypotension. And in fact, guys, let me just say this, as nurses, anytime a patient, whether it starts on a beta blocker, calcium channel blocker, ACE inhibitor, ARB, or an alpha blocker, when they first start those medications, they should always watch for orthostatic hypotension, because it takes the body some time to adjust to those medications. So I always try to teach my patients when they first start them to, sit up on the side of the bed a minute, then get up. Don't just jump up, or what happens is their blood pressure could bottom out because the body is not used to that medication yet. So your alpha blockers are notorious for orthostatic hypotension, especially when they first start taking them. Here they are. They are your OSINs. Your alpha-1 blockers are your OSINs, O-S-I-N. Now, these first three are used for hypertension. This last one, tamsulosin or Flomax, this is the one used for BPH, or benign prostatic hypertrophy. So that's why I always try to teach my nursing students, even though you are giving this patient with BPH for urinary frequency an alpha blocker, they have to know the side effects, which are orthostatic hypertension, because they're not going to think about that. They're like, I'm taking this, to help my so I can, pee better. So again, that's why it's important, very important, because a patient could fall out because we didn't educate them properly, and that shouldn't happen. This medication is called an alpha-2 blocker. So it blocks the alpha receptors. It does it differently. Alpha receptors in the brain itself. So that is why this medication, clonidine, also brand name Catapres, clonidine can be used to treat hypertension, but because it blocks alpha-2 receptors in the brain, it's also can be used for anxiety, clonidine, okay? This is just a summary of meds. I wouldn't spend much time looking at that. It's too busy for me. So like I said, alpha-1 blockers, when they first start taking them, make sure the patient knows about the orthostatic hypotension, okay? With that, if they get dizzy, the blood pressure falls. It's like if they get up really quick, and then with the drop in that blood pressure, of course, the heart rate's going to go up. So alpha-1 and alpha-2. This is just one of those picture, just to help you remember things, okay? But orthostatic hypotension is truly a big concern with the OSINs. Okay, I'll go over, actually, I think I'm going to stop there. So when we come back on Monday, we will go back over our medications, and then we'll continue to go through these slides, looking at our drugs for high cholesterol, our nitrates, our diuretics, what are the other ones? Anticoagulants and antiplatelets. So there are a lot of medications. So we'll go back over that. So, but I did, like I said, because I knew this would not be enough time, that I posted the voiceover. So that way you can listen and still take notes and hopefully be a little bit more ready to go with this on Monday. Okay. Let me stop sharing my screen.
Ms. Rimble, I have a question.
Yes.
So other than the alpha blockers, the orthostatic hypertension, what other drug class did you say that it caused orthostatic hypertension as well?
Really, your beta blockers, calcium channel blockers, even your ACE inhibitors and your ARBs. When those patients first start taking that medication, they need to be aware to sit up on the side of the bed and not jump up quickly.
Thank you.
The reason that's for, the ones I just mentioned. And that's why I point out specifically tamsulosin, because I've been in the ED with students, and, the man gets a prescription for tamsulosin and they didn't teach him, if you jump up quickly, you can fall out. They have to be educated about that. So just make sure you incorporate that in your teaching, because someone could get hurt.
Thank you.
Anything else, guys? Okay, well, I'll get those invites out, and I do record, so I'll be posting this as well. I will see you Monday. Okay.
Thank you.
Thank
you.
Bye-bye.
Have a good weekend.
You too.